So, we start with local anesthesia, going on the buccal aspect. We use articaine with vasoconstrictor 1 to 100,000. It is very important to give the anesthesia slowly to avoid having swelling of the soft tissue, and we can go lingually either in the lingual pavement or very superficially on the lingual aspect of the second molar. Always remember the position of the mandibular ramus to decide the flap design. We always go and do a palpation of the vertical aspect of the ramus to see where it diverges towards the buccal aspect, and we see that we found it, and it doesn't go directly in correspondence to the second molar, but is quite distal and buccal. So the flap design is going to be intrasulcular, a triangular flap with a releasing distal incision that has not to overcome the sulcus in between the vestibular and lingual cusps, and has to diverge on the very buccal side aspect, and it has to be a full flap incision. So we test that the anesthesia has performed its effect. We ask the patient if he feels just some pressure or some pain. As we said, in almost 90% of my surgeries, I don't do any more full block anesthesia. We see the ischemia of the vasoconstrictor. We check that there is no pain in the maneuvers that we are applying. Now we are ready with our scalpel to draw the incision we had planned intrasulcular till the distal part. We don't overcome the sulcus in between the cusps from the vestibular and the lingual aspect, and from this point, so from the distal buccal cusp, we diverge buccally and distally towards the ramus, trying to feel that our blade touches the underlying bone. And this is important to elevate a full thickness flap with its periosteum without leaving periosteum attached on the bone. So now we are ready to detach and elevate the flap using our elevator, which we use using the concave part towards us. We try to find the correct bone plane, and once we find the correct bone plane, we pull towards the buccal aspect as if we were opening and turning the page of a book, and we see that our impacted tooth was directly under the mucosa. We have to find where the periosteum detaches, and once we find the detachment of the periosteum, then we can follow and insert our elevator, pushing it on the buccal side to elevate a complete full thickness flap. And we know that these teeth that have had inflammation can have inflamed tissues superficially, which aren't always easy to manage. So we have to be very gentle, and once we find the correct separation plane, then we are ready to protect the soft tissues. But now we feel that there is tension in the flap that we have designed, so we have to continue our elevation, trying to remove the tension, because we know that we have to have a tension-free flap elevated in order to avoid laceration of the soft tissue, for example, towards the papilla, the mesial papilla of the seventh tooth. So once we found the bone aspect, then it's easy to pull backwards the flap and the periosteum in order to have the correct vision of the tooth.